I'd like to introduce the moderator of our next panel. Maryce Ramsey is a senior gender advisor in the gender department at FHI 360. She is based in our Asia Regional Pacific office in Bangkok and is going to be talking about challenges to providing gender-based violence services to adolescents. Maryce?
Good morning, everyone. Welcome back. Grab your coffee and take a seat. I'm freezing up here, so I'm going to keep drinking my coffee. I don't mean to be rude, but to see if I can get some circulation going again. So we're going to be looking at challenges to providing GBV services for all adolescents. I think we're going to do more, though, than just look at challenges. Hopefully we're going to move beyond challenges, but we'll certainly raise some of the challenges. And we're going to be talking about different populations of adolescents. So what do we mean by that? I'm joined this morning by 3 distinguished panelists, and I would direct you to their full bios in your folders that you received yesterday. Each one will be talking about a different group of adolescents. UNAIDS uses the term sex worker. They say that it applies only to those who are over the age of 18 and those who engage in consensual sale of sex. And so those who are under the age of 18 cannot give consent and therefore are not technically sex workers, and that's in compliance with the Convention on the Rights of the Child. However, our first panelist is going to be speaking about young girls who have self-identified as sex workers. And so we'll hear from Parinita from Manitoba. I'm sorry, not Manitoba. So we'll hear from Parinita first, who's going to be talking about young girls who self-identify as sex workers. She'll be followed by Robyn, who's going to be speaking to the needs of young men who have sex with men and transgender women. And our final panelist is really going to focus in more on adolescent girls. Okay. I wanted to do a little bit of setting the stage for this conversation, although I have to say Mary Ellsberg did a lot of that, so I may flip through some of this pretty quickly. But the first thing that I wanted to cover is really how are we defining gender-based violence? Because when we talk about providing services to all adolescents, the way that we define gender-based violence can define adolescents into the services or define adolescents out of the services. So we look very broadly at gender-based violence in terms of violence that's directed at an individual based on their biological sex, gender identity, or perceived adherence to norms for masculinity and femininity. And we look very broadly at physical, sexual, psychological, economic violence. And it covers things ranging from actually pre-birth, so sex-selective abortion, all the way through old age, looking at child sexual abuse, sex trafficking, neglect, intimate partner violence, elder abuse, and I have to just say something here. For some reason, once you pass through menopause and can no longer give birth, somehow you cease to be a woman and become an elder. So we no longer call it gender-based violence because you are too old to give birth. But anyway, that's a pet peeve of mine. And we also cover early enforced marriage, honor killings, and female genital cutting. So again, how we define this issue defines adolescents in or away from services. There we go. I have to thank Together for Girls for allowing me access to some of their slides on data from violence against children surveys. I think as we heard from Mary, the levels of violence against children, sexual violence, are very high. And when you look at this particular slide, you'll see that nearly a quarter of all girls in each of these countries have experienced sexual violence prior to the age of 18, and that for boys, that number is basically 10% at least. For more than 1 in 4 girls, their first sexual intercourse was unwanted. That's an extraordinarily high number. We don't have broad surveys to look at other populations of adolescents, but we have some data from here and there that we have. In 2011, FHI 360 did a IBBS in Port Moresby, Papua New Guinea, and though it wasn't focused on adolescents, there were young people in the survey. It was among female sex workers and men who have sex with men, and in that survey, They found that 78% of the women had been raped in the last year, and 58% of the men who have sex with men had been raped in the last year. What's interesting also from that particular survey is that they also found that 32% of those women who had sought STI, sexually transmitted infection treatment, were turned away because of their sexual behavior, and 13% of the men were turned away. And I think we'll hear more from Robyn about some of the violence against men who have sex with men and transgender women as well. Roughly a third of women who are between the ages of 20 to 24, or 67 million. I mean, I can't even comprehend. 67 million in developing regions are married or in union before their 18th birthday, and nearly 12% before the age of 15. And yet, when these adolescents and young women come into health facilities, they're often not seen or treated as adolescents because they're married. They're just seen as being married women. Women and girls make up the majority of those who are in forced labor, and 98% of those who are trafficked for sexual exploitation. And that is often a way that girls end up in sex work. We certainly heard that in Papua New Guinea when we were talking to sex workers there. Whenever we talk about gender-based violence, we oftentimes position the work that we do on gender-based violence as being important because it's affecting other development outcomes of interest, and that's incredibly important. We heard a bit about the impact on school outcomes, educational outcomes, enrollment, retention, completion, and all of the negative impacts on health outcomes. But I think we also need to be able to talk very bluntly and upfront about this as the ultimate abuse of power. Gender is about roles and relationships and the power in those relationships, and this is the ultimate abuse of that power. And we need to talk about this as a human rights problem first, but also something that impacts other development outcomes. We have a global epidemic on our hands, and if it were an epidemic of any other thing, we would be hearing about it every day the way that we do about Zika. I'd like for there to be more of a sense of urgency around addressing gender-based violence as an epidemic. So in terms of some of the effects on other things such as health, 1 in 3 young women in sub-Saharan Africa who had experienced pressure to physically force sex reported a resultant pregnancy. And we know of all of the other consequences for women in terms of death, physical injury, unintended pregnancies, induced abortions, STI, and on and on. Women who have experienced violence are up to 3 times more likely to be infected with HIV than those who have not experienced gender-based violence. A study that was done in the region where I work, in the Asia-Pacific region, among female and transgender sex workers across 4 countries in the region, found that gender-based violence in all of its forms was most often the result, the impetus for them entering into sex work. And ironically, once in sex work, then their likelihood of experiencing gender-based violence goes up from there. Parinita is going to talk a little bit more about the relationship to HIV outcomes for those who are engaging in sex work, and Robyn will be talking a little bit more about men who have sex with men and transgender women and the effects on their health. We look at the impact of gender-based violence on those who are experiencing it, but there's also a negative effect on the men who are perpetrating this violence in terms of their own likelihood of being at risk for things such as HIV. So men who use violence against their female partners are more likely than non-violent men to have multiple sex workers, to have multiple sex partners, to frequent sex workers, and to use alcohol to have an STI. So it doesn't just stop with those who experience the gender-based violence. This is also a slide from Together for Girls, looking at, in Nigeria, asking children how many had witnessed gender-based violence in the home growing up under the age of 18. And just looking at the left circle there, 66% of the females and 58% of the males had witnessed that. And this becomes important because we know from studies all over the world that boys who witness violence in the home are more likely to grow up to be perpetrators of violence, and girls who witness violence in the home are more likely to grow up and enter into relationships where they experience gender-based violence. So there's a reason why this is up there as a circle. It's really the beginning of that cycle of violence. And again, a last slide on from Together for Girls, looking at, I think we heard a little bit about, one of the last panelists mentioned that only 10% of those who had experienced sexual violence ended up seeking help. But if you look at this slide, you can see that this is from Kenya, and of the girls who had experienced sexual violence, less than 50% ever told anyone. And for the boys, less than 36% ever told anyone. From there, then, you look at, of those who told someone, look at the huge drop, the precipitous drop-off from 46% of the girls telling someone to only 7% actually sought services. And from those who sought services, again, a drop by more than half to actually receiving those services. So what a teeny fraction actually access services. So we're talking about services, but the reality is that, I think Annie will talk about this later, but for those organizations and those places that are offering sexual violence services, we often see that the majority of those who come in for services are under the age of 18, and oftentimes the majority are under the age of 15. So if we're already seeing that the majority of those who seek services are that young, but we're only seeing a teeny percent, which doesn't even show here, a teeny percent actually ever receive those services, how many adolescents are out there who have experienced sexual gender-based violence and never, ever, ever access any services? So I've been teeing up really some of the challenges and some of the breadth and the depth of the issue, and I'm going to turn this over now for Parinita to begin to talk to us a little bit about working with girls who self-identify as sex workers.
Good morning. Somebody has to be sick in the Gender Summit, so it's me this time. So apologies, you're not going to hear my best voice. But thanks so much to the organizers. It's not very often that I get a chance to speak in this kind of a forum. I'm more used to a HIV or a key populations forum. But when I got this opportunity to talk about young key populations, I couldn't say no. I'm going to talk about girls, young girls, and Robyn's going to follow up with transgender and MSM. There is some evidence that adolescent and young people from key populations, they are at very significant risk of HIV. But there are huge policy and legal barriers that, especially related to age, which often prevent access to range of health services, or even for service providers to address the needs of women or girls who engage in selling sex below the age of 18 years. Obviously, there are a huge amount of fear and experience of stigma, discrimination, and violence that keep these young girls away from services, away from even acknowledging or coming out and saying that they are engaging in high risk. And there's very less reliable and representative data on adolescent and young key populations, which makes them actually quite invisible in the key population program. The recent WHO guidelines on HIV prevention, diagnosis, and treatment and care for key populations actually acknowledges that the needs of young people from key populations are neglected, both by programs designed for young people, but also those designed for adults from key populations. So an adult female sex work program doesn't really address the needs of girls below the age of 18 or even up to age of 2024 because they are kind of left out. So I'm going to share a little bit about a study that we did, a study called Transitions, which the goal was to understand the transition period from first sex, the sexual debut, until self-declared entry into sex work, the access gap that young girls have, and to also examine the importance of this early HIV risk for epidemic control. I must say that the study was funded by CIHR, Canadian Institute of Health Research, and was approved by the Kenyan Ethics Board. And the study was also done in partnership with the government of Kenya, but also the CSO, ICRH, in Kenya. And it was done in 2 countries, Kenya and Ukraine. In Kenya, we chose Mombasa. It's a coastal city. The methods used were mapping, cross-sectional survey, including behavioral and biological markers. The sample size in Kenya was 1,299. So we interviewed girls from 14 to 24-year age in 3 categories. Girls who engage in casual sex, girls who engage in transactional sex, and girls who self-identified themselves as sex workers. And all these 3 categories were very well defined. So respondents had to identify to which category they belonged to, and they were administered a questionnaire for that specific category. And the definition for sex work is clearly defined over here. So what was very interesting, that the definition, the difference between transactional sex and the sex work was the sex work was when, during that act of, it was considered as sex work when the price of sex is negotiated and both parties have to agree to the price of sex before the sex event takes place. And the money is paid before or immediately after the sex event. And that's what the difference between transactional sex and the sex work was. So around 408 girls identified themselves as selling sex for money. So some of the findings, as I said, the study was done in Mombasa, Kenya. In terms of the profile of the respondents, we found that 42% of the respondents were between 14 to 19 years and 58% were above 20 years. The mean age of participants was 20 years. What was interesting is that the sexual debut age at sexual debut was 15.5 years, the mean age. Around 58% of the girls, the respondents, had a sexual debut between the age of 14 to 19 years, but around 35% had a sexual debut even below 15 years. The number of years before that they had a sexual debut or sexual act was around 4.3 years, but duration in sex work has been 2.2 years, which of course means that the sexual debut happened almost 2 years before they self-identified themselves as sex workers. So around 41% of the girls interviewed have been in sex work for 1 to 2 years, but what's interesting is around 14% has been also in sex work for more than 5 years. So if the mean age is 20 years, possibly they have been in selling sex for money at the age of around 15 years. Most of the respondents said they were selling sex at venues, around 60%, and around 16% were in the streets, and the remaining were in home and massage parlors. The weekly client volume was around 5.7, around 6 clients a week, and in Mombasa we find that sex workers in general have around 10 clients a week. So even for young girls who are selling sex, the client volume is pretty high. In terms of violence, we found around 18% of respondents reported that the first sex, the sexual debut, was forced against her will, and 48% said that they felt coerced or deceived into having sex at first sex. 30% reported experiencing force to have sex, and 39% responded experiencing any form of violence in the last 6 months. 16% responded having some violence in the last 1 month, actually. What we also found was that regular clients and first-time paying clients were the main perpetrators of violence. Physical violence was around 28%, and sexual violence was 26%, though they're not mutually exclusive. because we are doing this research in the context of HIV, we looked at the HIV outcomes, and this was very interesting because we found that huge amount of, and significantly, respondents who experienced violence either ever or in the last 6 months had higher prevalence of HIV. And respondents who experienced forced sex or sexual violence had significantly lower consistent condom use, which obviously links to HIV. We also looked at access to services. Now, everybody knows peer education programs is one of the main programs of a key population program, but we found that 14 to 24-year-olds, around 86% had never been contacted by a peer. And 91% have never actually reached any program clinic. So normally in a key population program, NGOs run clinics for STI or HIV, and 91% had never even reached some of those programs. And Mombasa has a thriving, very good HIV prevention program for key population for female sex workers in the city, and it's a long-standing program. However, what was interesting is that we found that around 70%, more than 70% of young girls were accessing HIV testing services. So they were, maybe it's because of the awareness and understanding that testing is important, they were actually accessing services, possibly in government or private clinics, but obviously because they were not part of the key population program, they couldn't receive all the other programs, other services that a key population program offers. There are quite a few challenges of reaching young key populations, and obviously one is the legal environment, and because of that, many key population programs do not want to touch younger girls. They can be accused of trafficking. Sometimes when they reach younger girls, they actually register them as 18 just to safeguard them, really. And obviously the inequitable gender norms. I mean, girls having multiple sexual partners are bad girls. So why should I come out and I say I'm doing sex work or I'm having multiple sexual partners? So let me stay hidden. There's also, I don't think we understand the multiple vulnerabilities and the diversity that is there, or needs of the young people. And I don't think our programs are designed to address some of that multiple vulnerability and diversity. And in many countries, we also don't have the options to address structural vulnerabilities, because when you work with young people in high-risk situations, you need structural interventions. However, what's interesting is that there are opportunities that do exist. I think our study very clearly showed that young girls, they are available in the venues where adult sex workers are practicing. So if we have to reach young girls, those could be the places where we can reach with services. And young girls are accessing HIV services. So can that be HIV testing services? So can that be an access point where we can provide more holistic services to them? Violence is a reality in their life. So can that be again an entry point to make them more included in the program? And besides, there are also other evidences now where we know what kind of programs work for young people. So can we also use some of those strategies to reach out to young people who are engaged in selling sex? So I'm just going to end with some of the recommendations that the government of Kenya and the programs in Kenya is taking up and actually looking at developing a policy. Is that, all services for key populations are applicable for young people, and all programs that look at young people should also address the needs of key populations within them. And we're also looking at examining current consent policies and considering revising them to reduce age-related barriers to access services. Also understanding that the intervention that needs to be designed should be multidisciplinary and should address overlapping vulnerabilities. It's not enough when we work with young people to do just harm reduction, give a condom and come back. I don't think it's enough. We need to address for 14-year-old, 15, 16-year-old, I think we need to look at more structural intervention. How do we send them back to schools? How do we send them back to families, possibly, if families are supportive? And there are certain programs, I know in India, the sex work program, DMSC, actually looks at young girls who are engaging in sex work and how do we address their needs. Also to engage them in decision making and actually asking them what they need and asking them what they want to identify with and asking them, evolving their strengths and capacities and competencies to make choices. So my last point is same as my first point, that I think inclusion of young people from key population in all programs for young people and all programs for key population is important. Let's let them not be ignored or be invisible anymore. Thank you so much.
Thank you, Parinita. Now we're going to turn to Robyn, who's going to speak to some of the programming under the LINKAGES Project.
Okay, so thank you all so much for being here, and to the organizers of this conference for taking, I think, important steps to try to be inclusive of different gender identities, different sexual orientations, because in these gender spaces we definitely need to be having these conversations. And I think thank you to the audience as well for pointing out that we always need to do more and that we need to keep pushing this until programs are truly inclusive of everyone. I'm going to talk about what the LINKAGES Project is in just 1 minute, but I really hope that at the end of this short presentation as well as the full day, that anyone who didn't come in convinced that we really need to work on the issue of violence against the LGBT community, and that we are collectively responsible for doing so and can do so, even though it will be challenging, that you'll come away with that sense of, yes, I am part of this, and yes, we need to do more. So the LINKAGES Project that I'm here representing is an HIV service delivery project. We both work to prevent HIV with key populations that you see here, as well as to extend life for those living with HIV. And I think looking at the project description, you're like, oh, where are the adolescents? Where is the violence? And full disclosure, and as Parinita said, there are barriers to working with young people, and we are trying to do more and more of that to make our services more youth-friendly, to really do that tailoring. But at this point, we are serving adolescents, but I think not to the extent that we really need to be. On the other hand, with the violence piece, we are very much addressing this issue across the countries that we work. And we do that under 2 of our cross-cutting areas. You see that we have gender integration as one, and so obviously gender-based violence falls under that. And then you also see this commitment to human rights. And again, obviously violence, such a violation of human rights. And because in HIV programming, I think in all of our programming, right, it needs to be this nothing about us without us, that when you work with communities to ask what they need, the first thing is not HIV services, and it often is violence services. So really taking that into account. A little bit more on the sort of key populations nomenclature. This is key populations most affected by HIV. And you see here that list of key populations, and then in parentheses afterwards, prevalence rates. So when it says 12 times higher, that means 12 times higher than the prevalence in the general population. And it also points to why we're not specifically talking about lesbians in this presentation. It's not to say that that is not a group that definitely needs services, but because we are really guided, our project is guided by HIV prevalence rates, this is who we're working with. And to narrow down further in this presentation, Parinita touched really eloquently on the issue of young women who sell sex. I'm going to speak to the issues affecting gay men and other MSM and trans women in particular, because I really want to be able to focus on transphobia and homophobia and the gender aspects of those. And I'm not going to talk about all 30 countries that we're working in, but going to focus in on 3, which are Cameroon, Kenya, and the Dominican Republic. Okay, so why? Why do we absolutely have to address this issue? Maryce shared some statistics at the beginning that touch on this point. I do want to note that the sort of least compelling reason, but an important one and why we're working in this area, is what Parinita alluded to around how this affects HIV risk. Violence also very much impacts HIV service uptake. People are less likely to be tested, less likely to disclose status, less able to adhere when they're on ARVs. So all of these make violence an HIV issue, beyond obviously the human rights element, which is the clear pressing concern. Violence against these communities is extreme. It's very, very prevalent for young people in particular. There's violence from families, violence at school. We see a lot of bullying, violence from police, violence in public spaces. A lot of psychological abuse, a lot of humiliation, a lot of reports of mobs of people taunting, screaming, throwing things in the street, just very, very visible violence. And this is really hard to quantify. There's a lot of underreporting. There are some other barriers as well that make it difficult to know. These are some figures from the Global Men's Rights and Health Study that were presented in a recent document from MSMGF. And it just gives you a sense of regionally, gay men and other MSM who report they experienced physical violence because they were gay or because they were MSM. So, really them looking at when this violence occurred, was it about my sexual orientation? Was it about who I have sex with? And for trans women as well, very, very, very difficult to capture this information. The Trans Murder Monitoring Project reported just recently on May 17th on the International Day Against Homophobia, Transphobia, and Biphobia that this year there have already been 100 murders of trans people essentially because they're trans. So that was from January 1st to the end of April. There's also the fact that this violence is so extreme. This is a quote from the United Nations 2015 report, and this is a picture of an office of a community-based organization in Cameroon that serves MSM and is led by MSM. So in December 2013, their office was ransacked, their laptops were stolen, their cameras were stolen, and it was graffitied with messages that said, "Next time we will padlock and burn you all inside." So not just individuals and communities, who for whatever reason may be visible, but those offering them services being targeted as well. And even more recently, a young man in Cameroon was taken into police custody and tortured into giving names of leaders in MSM organizations. So just thinking about, individuals and communities, but also these service providers and the issues that they're dealing with. So I think I've touched on this first one, why there may be limited key population-friendly violence response, in particular from those in the community offering services, which is often a big portion of where services come from. So would a trans woman, would a young MSM have the opportunity to go to an ER, have the opportunity to go to the police? Often, the answer is no. You can't go if you go to the police, especially in areas where either homosexuality or gender impersonation are criminalized. Then you're gonna have to admit to breaking a law to get a service, and then you yourself may be incarcerated. For clinicians, tons of stigma and discrimination, thinking that people put themselves at risk, this whole, you deserved the violence, you were the cause of the violence against you. There's also, if there are services available, limited service seeking. A real distrust in services, as I think we can imagine would exist, as well as some norms, particularly for MSM, around I shouldn't have been a victim. I'm a man. I shouldn't seek help. I'm a man. As well as the fact that if you're going to go to a center that's openly LGBT, that means you have to out yourself. And for young people in particular in these populations, if you're still living at home, you still receive support from your parents to attend school, you don't want to do that for many reasons, but also because then you lose their support. And then connected to this piece, if you have been bullied out of school, if you have been forced to leave your home, obviously you have less access to information and to support structures than you might have had otherwise to learn about services available. These are quotes that really point to the issues behind the barriers. In this case, the perspective from MSM are in orange and those from trans women are in green. They're from focus groups that we conducted in the Dominican Republic about reasons for not seeking services. I'm not going to read these, I think you can read them for yourself, but just to point out that obviously in some cases looking for help is really an unfathomable idea to people, that further emotional violence is inflicted on individuals when they seek help, and that when people who are supposed to be helping you are actively perpetrating violence against you, obviously you're not going there for services. What are the gender issues behind these barriers, and why is this part of this gender conference? So we had the opportunity to ask in Kenya this question specifically through a gender analysis that the project just did, and these were some of the issues that came up particularly for MSM and trans women, that these groups are considered to be degrading themselves when they behave in a feminine way. So, you know, you lost your chance, right? You decided to degrade yourself, you deserve what happened to you, directly in line with the second one, that by acting like a woman, you've made it acceptable for violence to happen against you because we accept violence against women. You know, I think as problematic, as insane as that is, it's so true everywhere, and it directly impacts these populations as well. The belief that violence against MSM or trans women could cure them. You know, I know we hear a lot about that, but that also came out in this analysis. And then finally, this piece around service-seeking behavior. These are some of the provider voices from Kenya. They're from program managers and healthcare workers working with trans and MSM individuals. Again, green representative of trans and orange of MSM. And you know, I think what you see here is a lot of this whole, what is manliness? That femininity is less than masculinity, and what it means if you violate the ideals of masculinity in terms of seeking services and being a man, and then what happens after you experience violence, whether or not you're willing to reach out for help. Oh, and it looks like blue, sorry, my screen. So blue is MSM, green is trans. All right, so what is Linkages doing? So like I said, we are very much committed to this issue. We are integrating violence response services into key population programming. So we have a lot of community-based organizations we work with who serve MSM, who serve the trans community, and we're making sure that they can also respond to violence. So for example, in Cameroon, we're helping to make sure that everybody is able to offer at a minimum first-line response, that you know the messages to make sure you're not blaming someone. You know the services they can get to. You can talk to them about safety. You can talk to them about the supportive networks that they might already be a part of. Second, we're making sure that key populations are integrated into services for the general population. It's not particularly sustainable to have parallel structures that are entirely for key populations, police that can work with key populations only, right? So we want, if there's a gender-based violence desk at the police office, that they understand that MSM trans women, violence against these groups is also gender-based violence. We've also had some success in the Dominican Republic where we're taking this up and thinking about how do they make sure their laws, which say gender-based violence, but then the victims that are described are all women, how can that be broadened and that really be a jumping off point for making services more inclusive? We're also making sure that we don't just talk about physical and sexual violence. We're doing research right now in Latin America and the Caribbean in 4 countries to really understand from the perspective of MSM and trans women, what does violence look like across your life? What are really the concerns that you have, the opportunities you have for service seeking, and going into emotional and even economic violence? What more can be done? Obviously so much, but just to touch on a few pieces, things that we're trying out, that there are often from the community requests that we work with families for young people, young MSM and trans people, because they do want to be reintegrated into families. So where that's appropriate, where it's being asked for, obviously never in this sort of reunification kind of with that as the goal, but with the goal of providing services that do no harm, that are client-centered, that when it's requested, we would be able to offer these support groups for families to understand their young people and to accept them and embrace them. Second, that for those key population groups we're supporting that may not be thinking about the youth angle in their violence work or in other work, that we help them to engage young leaders. This is a picture from the Dominican Republic, and the person who's the third from the left is a peer educator, a young peer educator for the MSM group, getting to meet with a lawyer, the guy wearing glasses, and then next to him, a doctor from an HIV clinic. So really exposing these young people as well to people in positions of power to give them those connections directly. And then finally, and again, this being my plea to all of us here collectively, what can we all do? Let's please focus on the gender part of gender-based violence. It's not violence against women if it's gender-based violence. It's gender-based violence. And let's, in our youth programming, let's educate on sexual orientation and gender expression and identity, that a lot of times perpetrators of violence are young as well, right? So not only do people need to understand themselves and their communities and their rights, but they need to understand that others have those rights. Let's tackle the underlying gender norms that cause violence and victim blaming. I know that's why we're all here, so let's just do that more broadly. And then finally, as much as possible, to be inclusive in our programming. You know, I think we can and we must do more. Thank you.
Thank you, Robyn. Our last speaker is going to be Banda from World Vision in Zambia, who's going to be talking about the work that she's doing there with the GBV Survivor Support Project. Annie?
Thank you. Thank you so very much for being availed this opportunity to share some of the experiences that we have from Zambia. I'm going to talk about a program called Stamping Out and Preventing Gender-Based Violence, which is funded by USAID in collaboration with UK Aid. Yes, so I'll briefly talk about the statistics. Yes, so in Zambia, we have over 43% of women aged between 15 to 49 reporting having had being violated physically, and this is according to the Demographic Health Survey. And then 47% of the ever married women aged between that age group, reported having had being violated by their either current or former partner, 12 months before the survey was done. And then through the program that we are working on, Project Data actually is showing us that out of the over 40,000 survivors that we've provided post-GBV care to, over 56% of these are adolescents that are aged between the age of 10 and 24. And then also, data from our project shows that over 84% of all the sexual gender-based violence actually is perpetrated against children and adolescents. And most of the perpetrators, and from our project data, most of the perpetrators are mainly perpetrators of violence against adolescents are mainly their boyfriends. I think the previous facilitator alluded to this. So I'll briefly, before we're talking about the challenges that we are facing in providing services to adolescents, I'll briefly just explain exactly what we are doing as a program. So this program has got three components. We have the first component that is looking at prevention and advocacy on gender-based violence. And then the next component looks at access to justice, so ensuring that the legal framework around gender-based violence supports service provision, as well as ensuring that survivors of gender-based violence are able to access services. So in terms of service provision, the program is working with a multidisciplinary team of service providers that usually constitutes of health workers, police officers, legal personnel, social workers, and counselors that sit in one place, usually a health facility, and then provide different services to survivors of gender-based violence, most of which are listed. Yeah, so we provide health services, we provide social services, and we also do counseling and testing and provide post-exposure prophylaxis where it is required. Okay, so I won't dwell so much on prevention, basically because I think the previous team talked about prevention. I will concentrate on service provision. But basically, as a program, we are working with both girls, and some of the models that we're using the GLOW model that is, we've adapted it from, that's Girls Leading Our World from Peace Corps. And then we also have other models that are targeting boys and young men. Okay, so what are some of the challenges that the program is facing in ensuring that adolescents access services, from the one-stop centers that we are using to deliver our services? One of the challenges that it's not all the areas in Zambia that have got service provision points for adolescents. So Zambia has got over 100 districts, and these one-stop centers are only in 28 of the 100 districts. So there's that gap in terms of service provision points. And also because of the cultural barriers, you'd find that, youths being scared of being blamed if they came and reported on gender-based violence, you find that most of them are not coming across to really access the services that are being provided, even in the few service provision points that we have. And then also, adolescents, most of them really are mobile in that, they'll get to school at one point, they'll get to college, and they at times need to go and look for jobs in other places. So you find that they're not able actually to access the whole package of service provision. So you'd find that maybe you need to counsel them for a period of 1 month, depending on the kind of abuse that they've suffered. But because they need to move, to another area, you are not able to provide that comprehensive care to them. And then the other challenge is that most of the adolescents report cases of gender violence quite late to our centers, and specifically sexual violence. So you find that they'll only come after a week, and by the time they are coming, then they will have to miss out on a number of services that they need to access. For example, it will be too late for us to administer post-exposure prophylaxis against HIV and AIDS, and you would have lost out actually on an opportunity to provide, to collect evidence that would facilitate them to access legal services later on and all that. And then initially, when we started implementing the program, I think we did not take time to really build in the needs of the adolescents, and as a result, we did not provide much capacity building on the service providers, for them to be able to really meet the needs of the adolescents, and so you'd find that the quality of services that our adolescents were getting at one point was compromised, but we've gone ahead and built the capacity of service providers to be able to meet the needs of the adolescents. Okay, so what has the program done to ensure that the environment in which services are being provided for the adolescents is conducive? We actually had to make sure that the capacity of service providers is built, like I mentioned. So we had to engage in child-specific trainings, adolescent-specific trainings, for example, on sexual reproductive health, just to make sure that service providers are able to meet the needs of the adolescents. We also had to make our service provision points safe for adolescents to come and report gender-based violence. Just speaking from experience and giving an example of how that at times adolescents would prefer to call in. We have toll-free numbers. They would prefer to call in and not visit the physical, place where they can get services, because they are not very comfortable, with probably they have issues of, confidentiality and all that. So we are working at, creating safe spaces for them to be free to come and report cases of gender-based violence, and for them to come and talk about, how they can protect themselves actually from getting violated. And then also we are using our service provision points as a point where we are able to link adolescents to other services. So when they come to report gender-based violence, we also are able to refer them, for example, to the ART program if they are HIV positive. We'll refer them to programs that are providing HIV prevention, services, for them to protect themselves. We'll refer them if they need to get back to school. We'll refer them to education programs and empowerment programs. And then also, like I think everybody has been talking starting from yesterday, engaging men and boys. So for us, we are not just engaging men and boys as change agents, but we are also ensuring that they also access services at the one-stop centers. Of course, we know that the majority of survivors that come to report violence are women, but we still have a good percentage of about 20% of of male that come to report. So we want to make sure that the service provision that they're going to get is of high quality, and the place is safe for men to come and report the violence. And of course, we've also gone ahead and ensured that our packages are targeted and are age appropriate. So instead of using one-size-fits-all approach, we make sure that we target the young adolescents with, a different package compared to the older adolescents. And finally, we've also ensured that we've built in some sustainability mechanism in our service provision. And we've done this in two ways. First and foremost, we have ensured that we have worked with most of the training institutions in the country to make sure that they integrate gender-based violence in the training curriculum. For example, the nurses training curriculum. So we worked with them and developed the curriculum, and starting last year, actually, all nurses that are getting trained are being trained on gender-based violence as well. And also the police service, we have also integrated gender-based violence in their training curriculum. Okay, so what are some of the lessons that we have learned, and what are the recommendations that we would like to share with other programmers that are providing post-GBV care to survivors of gender-based violence? Yeah, so probably before I talk about the lessons learned and the recommendations, just to really maybe bring a human face to the challenges that we have on gender-based violence. So when you talk about people coming to report gender-based violence, you're talking about a woman who has been so badly beaten, and at one time they were very active, they were doing their own business, but they've lost their sight, and they've been told you will never see again, following the abuse. You're talking about a family where 3 of their children were being actually sexually abused by an uncle, and they've reported late to the center, and all the 3 children have been infected with HIV and AIDS. You're talking about women that come to the center, and before you provide the service, they die. So really, it's an area that is very, very traumatizing, especially for service providers. And so when it comes to service provision, I think we really need to make sure that we pay attention and we ensure that the quality of service provision that we are giving is really good. Yeah, and then so some of the recommendations that we would like to share is that we really need to make sure that even as we are engaged, especially in prevention interventions, there has to be evidence that the approaches do work. And then also we need to make sure that service providers are well trained, and we need to keep retraining. We need to really invest quite a lot on training. And just from the few experiences that I shared, we realized that service providers actually can really get stressed with some of the situations that come through to the one-stop centers. And so there's just need to equip these service providers with skills on how they can just take care of themselves and take care of their well-being as well. And then also, I think I cannot emphasize the need of ensuring that the service provision point is safe for adolescents to access the services. Yeah, and actually maybe sharing more on how that boys from the data that we are collecting actually prefer calling in to report, an incident of gender-based violence. So when we get data from our toll-free numbers, you'd find that the number of boys that call in to seek services is almost equal to the number of girls that are seeking services through the telephone. So boys would rather call in than come to the center and provide services. There's need to make sure that there's disability inclusiveness. Disabled adolescents are more likely actually to be abused. And it's just important that at design, as well as we are implementing, we make sure that disability is included. And then there's also need for a coordinated response at all levels. We're talking about at national level, we're talking at district level, but also at service provision, level. We need to make sure that our efforts are coordinated so that, we provide quality services to survivors of gender-based violence. Yeah, and then we are privileged now that most of our youths, even where I come from, they have access to social media. So an opportunity for us to use social media to reach out to as many youths as we can. And of course, we still need to engage men and boys to make sure that we provide comprehensive care of service to our survivors. So I'll end here. Thank you so very much.
So I think we've run pretty long here. I had some recommendations. I think I'll just quickly touch on one or two of them and skip over the ones that have been mentioned. One of the ones I think that I would highlight would be that we need to offer comprehensive gender-based violence services at the lowest level of health facilities. It's great to have one-stop shops in capital cities where many people live, but the reality is in a lot of places, the majority of those who experience violence live in rural communities and cannot access one-stop shops, or even in big cities like Port Moresby where there's violence, you can't travel from one neighborhood to the next. Those who come in for sexual violence services, almost every place I've worked on this issue, do not access services in time to receive emergency contraception and post-exposure prophylaxis. So I think we really need to look at how do we get services to the lowest level and make them more accessible. One other thing I think is really important is the need to intervene with those children who have witnessed gender-based violence in the home. This is where prevention and response kind of overlap. In many places I've been into shelters, you see the children who are there with their mothers who've experienced violence, and the kids are just sitting on the floor playing with toys, and we're survivor-centered thinking that the mother is the survivor. The children are also survivors, and we have to figure out what is the appropriate response and intervention at that point to begin to intervene in that cycle of violence. And I think the last thing then would be that when you look at that teeny percent of people who ever access services, the reality is that we know that gender-based violence survivors are accessing health services. They're just not accessing them as survivors of gender-based violence. They're in antenatal care because they're pregnant as a result of violence. They're in the emergency room because they've induced an abortion as a result, they were pregnant as a result of violence. They're in the emergency department because they have wounds or broken bones. They're in the STI department because they're there as a result of sexual violence. Every healthcare provider needs to be able to recognize someone who's experienced gender-based violence so that they can get all of the services that they need. So I'm going to stop at that. We only have time for one round of questions. My attention span is very limited, so I'm going to ask for one question, and then we'll have one response, and then we'll go to the next question, if that's okay. Okay, so I saw the hand in the back go up first. If you can get a microphone, introduce yourself, please tell us where you're from, and then direct your question to the person that you're interested in having respond.
Hello everyone, I'm Meher Manzoor. I'm a Fulbright scholar from Pakistan studying at Tulane University. And my question to you is that often we see gender-based violence and we neglect the fact that HIV and STIs also come in the form of violence. And especially in case of African regions, we have seen that women don't have they're the gender and power dynamics within the households between men and women, that women cannot negotiate the use of contraceptive use, which also leads to HIV. So how are we incorporating the use of mass communication in addressing this issue? Like, I think TV, radio, these are information tools that can empower both men and women about this issue. And I think these powerful tools have been effective, but have been not used and incorporated that much. So I would like to hear from all the panelists, how are you incorporating mass communication in your tools? I hear that you've used social media as a tool, but most often these are, especially for the adolescent girls, maybe they don't have access to technology to go to social media. Maybe they have a TV at home, maybe they have a radio at home. So how can we incorporate these mass communication tools to address both the gender-based violence and the prevalence of the HIV in regions like these.
Okay, thank you. So I think maybe can we have one panelist respond? Annie, do you want to respond to that? Thank you.
Thank you. Yes, so basically, you were right. We also use mass communication to communicate both prevention messages as well as creating awareness about the availability of services, in our centers. And for rural-based communities, actually, we are using a mobile video units. This is, you show messages on gender-based violence, usually in the evenings when people are done with their work, and then you come and watch a movie on gender-based violence and then discuss around that. And we have seen this really working so well in rural communities. Yeah.
And one more question. Yes, the lady over here. Person in front in the black shirt. Thank you.
Hi, everyone. Hello. I'm Amanda Moskal. I am from Comonix. I am directing this question to Robyn. You briefly touched on training GBV advisors or points of contact at different social service providers. I'm wondering if this was in also like police stations and hospitals, only because I'm trying to reconcile the legality of these different services and the obligations that these contacts may have versus the sensitivities or the trainings that we would ideally want to provide them. So maybe you could speak to that for a moment.
Yeah, thank you very much for that question. So yes, you do certainly have to work with clinicians in hospitals and police stations. And I think the approach, and honestly Parinita has quite a bit about this as well, but the approach ends up being a really human rights-based approach, right? So no one deserves violence because they are MSM, because they are trans, because they're a sex worker. And so regardless of the legality of your behavior, like if I'm out drunk in public, disorderly, and someone assaults me, I was still assaulted, right? Like whether or not you know what I mean? Like it's going back to this point of you cannot deserve violence against you, and that's what these providers need to be able to address, regardless of the legal framework that this person, that they might have about this person's behaviors, and certainly that there also are ways, or their identity or sexual orientation, but so really focusing in on the human rights angle, and in that way also making sure, because these people are perpetrating violence, that they see where the fact that they're perpetrating violence is also completely unacceptable regardless of legality. So hopefully that, and we do have some different trainings that really bring that back to the gender side and help people see where the same norms that are affecting all men and women and boys and girls are affecting their stigma and discrimination toward these populations, and trying to help them really just overall interact in a much more respectful way.
And one more question. Yes, right here in front. Yes, please wait for a microphone. It's coming.
Hi, my name is Pamela Christ, and I'm currently an educational advocate working primarily with people with disabilities. And Annie, I want to thank you for bringing disabilities to the table. It's the first time I've heard it mentioned in this conference. And as people with disabilities are such a huge percentage of our population, they're obviously going to be impacted in all of the issues we're talking about with youth. I don't know if, Annie, you can speak specifically on some of the access issues you have with people with disabilities in terms of gender-based violence, or even, Parinita, I know that in India there's a significant population of people with disabilities, and it's such a huge country in terms of how do you address that. Thank you.
Thank you. Actually, when it comes to disability, even just for us to know that violence is happening is so difficult, because at times families with children or adolescents that are disabled do not even allow them to interact with the rest of the community. So it's even difficult for us to know if they exist. And in times that probably they have become aware on the need to report, and they come to report, and want to access services, you find that even just the physical environment actually is not tailored, to for them to be able to access services. We, as a program, we've had to remodel our offices, to just make sure that, for example, if somebody's disabled and is on a wheelchair, should be able to get into the office and access the services. Even looking at our current training materials, for example, disability is not included. So we are currently negotiating with the government so that we include that. So it's both at national level, at service provision point, where even the service providers themselves, we had a really very disheartening situation where a girl that could not talk and could not hear was sexually abused, and unfortunately it was a situation where the family had to leave that place because they were illegally staying there, and the girl was not home when everybody was leaving that area, and then in the process the girl was abused by about 4 men. And when this case was reported, we were not able to locate the family, and it took us over 6 months for us to be able to locate the family so that the girl could be reintegrated back into society. So really, issues of accessibility, both at service provision, in terms of service providers not having the skill, as well as the guidelines that we have at national level have not incorporated disability. Yeah.
I'm afraid that we've reached the end of our panel, but I would like to first of all thank the panelists, and secondly encourage everyone to seek out the panelists if you have questions that didn't get answered, and to continue the conversation. Thank you.
Thank you so much. Great panel. We're going to take a lunch break, and I'd like to ask everyone to be back in the room promptly at 1, where we're going to start our very dynamic lightning speaker round. Enjoy lunch.